school teacher. Good morning, everybody. It's really nice to see you again. And sounds like the weekend was good. I hope you had a good visit to Mount Bruce yesterday and saw some sheep shearing and a bit of Kiwi culture, and had time for a rest and exploring around on Saturday. So you're all looking quite refreshed this morning. So it's my pleasure to introduce Dr. John Weaver, who's our speaker this morning, speaking on implementation of disease control programs. Dr. Weaver's got considerable experience in managing disease control programs. He's working with Food and Agricultural Organisation, or has been since 2006 in Indonesia, with avian influenza control in Indonesia, and currently in Vietnam. And has previously done contracts for OIE, the World Animal Health Organisation, reviewing veterinary services in a number of countries, and his particular interests are in socio-economic factors influencing disease control programs. And he's started off in life as a veterinarian in practice. Actually has got quite a strong connection with New Zealand, which I hadn't realised at the time of inviting him. So he's got strong family roots here in New Zealand and Australia and Britain, so he's got a number of bases covered. So yeah, John's got an extensive background in private practice and in implementing national and regional disease control programs. So it's a pleasure to have you here this morning, John, and to give us the benefit of your experience in the challenging area of actually making these programs work.
Thanks, Joe. All right. Okay, good morning, everyone. Can you hear me all right? All the electronic gadgetry's working. That's good. Well, thank you very much to the Epicenter for inviting me here today. Thank you all very much for coming early on a Monday morning. It's always good to see people bright-eyed and bushy-tailed, so that's good. Thank you. It's a great pleasure to be here. As Joe has already mentioned, I have a sort of strong lineage in New Zealand, so it's always nice to sort of come home, although I haven't lived in New Zealand for 10 years. Both my parents are really from New Zealand. So it's nice to come here, and I have sort of huge respect, as we all do and the international community do, for the Epicenter and what the Epicenter has achieved. So it's a great pleasure to sort of be invited to give you this lecture this morning. What I want to cover is the implementation of disease control programs. And to be quite honest, I've had real trouble with this talk. I started off writing it one way, and then I thought, no, this is wrong, and I wrote it another way. I tried to encompass everything about implementation aspects of disease control, and it became too big. And then I was told it was only 1 hour and it was not to encompass the whole morning or the whole day. So I've tried to sort of focus it down a little bit. With some good advice from some colleagues here, I've tried to bring it back into some more practical issues of specific implementation issues rather than some of the higher level issues, but I still want to refer to those. So I think implementation of disease control programs is extremely complex, and this is something that all of the talks I think that you've been receiving last week and will continue to receive this week, they intertwine, they reference different aspects of the issues of disease control. Joe's mentioned that I have an interest in sort of socio-economic factors, and I guess sort of technically I have an interest in disease surveillance, but all of them are necessary and relevant to the implementation of disease control. So what I want to try and cover is issues of planning, and then go through into issues of implementation and some practical issues of implementation. I do want to talk a little bit about vaccination, and then some issues of surveillance monitoring, how you conclude a disease implementation control program, and then perhaps a little bit of time on a case study. Now, I've got far too many slides, so please excuse me if I suddenly skip through 2 or 3 to catch up. I did think about trying to broaden the issue in terms of considering a range of different zoonotic diseases, but that became too confusing, I think. So what I've largely concentrated on is the issue of HPAI, avian influenza control, and I guess my particular experiences in both Vietnam and in Indonesia. I will, if we have time, have a little bit of discussion on some case study on a particular rabies situation. So I think the first thing that is so important, I think if we don't get this right, then we should all stop now. We have to get the planning process of implementation right. So the issue of strategic planning. Where are we trying to go? How are we going to get there? So the issue of setting up a comprehensive strategic plan. And I know, where I think, maybe this is an assumption, but we're all, by and large, government officers or academics. We all have experience in this area. But we tend not to do it very well. And I think if we don't do it well, we have the problems down the track. We don't have the coherent plan that we need, the adaptive plan that we have to, over time, adapt as the situation changes. So we need a strong strategic plan. And that requires a lot of thinking before we start. And we need to consider all these different disciplines, issues, as we're aware, we're in an epicenter, so the core issues of epidemiology and surveillance, the understanding of disease, but also how we might manage it. So different diseases, different opportunities for risk reduction measures, perhaps the use of vaccine. Issues of communication, and something I want to come back to as we go through this talk. If we do not take people with us, we will fail. And communications are absolutely critical at all levels of disease control programs. Issues of resources, issues of diagnostics, issues of laboratories, laboratory capacity, laboratory quality control. And then some of the issues of governance, issues of legislation, the ability to control the risk factors, the abilities to control animal movements. So we need to identify these strategies, how we're going to use them within our strategic plan. And we need to document them clearly, because this is a document that we then have to sell to our political masters, the financiers. Underneath the strategic plan, we have our vision as the strategic plan with the core strategies. We need a documented, budgeted work plan. So this is getting down to the hard activities, what we're actually going to do. And that needs to be specified as clearly as possible with clearly defined activities, and they must be budgeted. Our masters, whether they're the government that are paying for this program or whether they're some co-financing with industry or with international donors, money is what will ultimately drive this. So we have to have clear budgeted plans for activities. And we need, under any good project or program management, we need M&E processes, monitoring and evaluation processes, so that we can review how we're going and adapt where things are not going right. And they will go wrong. Unexpected things will always happen, and we need to be prepared for that. We need to be careful that we protect this commitment, this issue of sustainability. It's all very well if we're in the firestorm of an epidemic and everybody is committed to the control program. But as we get more and more in control of that epidemic, that outbreak, or the endemic disease we're dealing with, it's harder to sustain that level of commitment. So again, we come back to this issue of communication, this issue of keeping the profile up so that we sustain the support that we need over time. And then in the operational planning, we also need to plan for the end. How do we actually wrap up this program in a successful way without losing all the advantage? This is a document that was written for Indonesia in 2006. So it was the operational plan. And you'll see that there are 9 key sort of areas. And I think if we think about the implementation of disease control, we can think about breaking down the task into these sort of areas. And you can always, this issue of lumpers and splitters, you could make them 15 different headings or you can make them 5. But we have to think about the different areas that we have to consider and we have to get right for implementation control programs to work. Again, at the top, management. We have to get the management of these programs right. Management of resources, management of the communications, so that we work both within the government system, within the industry system, and within the broader communication. Issues of disease control, the actual disease control activities, whether we're going to cull things, treat things, vaccinate. Understanding how we're going, so issues of surveillance and understanding the epidemiology. And then resourcing issues, again, laboratory services, issues of movement control and quarantine. Legislation is often something that we struggle with in developing countries in that the legislative powers are not adequate. So again, it's something we have to consider at the beginning of the process and try and make sure, maybe they're short-term decrees or regulations. Maybe over time there have to be stronger animal health acts. So we have to think about our legislative powers and whether we have adequate powers to make the control program work. Issues of research and development, particularly perhaps in my context in terms of HPAI. Have we got the best type of vaccines that we can use in the situations that we're trying to use them? Are there some opportunities to improve that? And then innate sort of risk management in terms of industry change. Can we reduce the risk of the current production and marketing systems of the industries we're working with? So management is critical. We really have to focus on tight program, or if you prefer, project management. We need organisational charts which actually identify the key players, the key structures that we need to work with. Issues of cross-cutting between different agencies and sectors. Issues of cross-cutting with health, with agriculture, with other departments, depending on how your governance system is set up. You know, you may have a department of communications and information. You may have a department of extension. All of these are key players in terms of how we implement this disease control program. So it's useful to map out the actual organisations that we need to deal with and then engage them and get them to become part of the program of implementing disease control. In terms of, and the focus is not so much in terms of emergency disease control, but in terms of emergency disease control, it's really important that you have clearly defined response plans, activity plans. So if you do have an emergency incursion, how are you going to respond to that? How you multiply up from being perhaps a single focus or index case or a few cases of infection to a broader area issue. How do you manage that resourcing issue? Prior planning and prior practicing makes for a much better coherent response and ultimately makes the whole response much more efficient and effective. This is an organisational chart taken from OSVET plan. At the end of, not so much in the notes that you have in front of you, but I think you're going to get a copy of this electronically. Thank you. Top button. Okay. You'll find some references, and this is a reference of, a diagram of the Australian system of emergency disease control. And I think the point I really want to make is that we need to consider these different areas. So we have planning managers, we have operations managers, and logistics. So logistics, all the things we need, staffing and equipment and transport. Planning, the epidemiologists and the technical specialists and the liaisons that are actually going to look ahead in terms of how things are happening. And then the operations, the actual day-to-day operations in terms of your disease control. I think there's something that is perhaps not very clearly specified here, again, is this issue of communications. That's both external communications with the various ranges of stakeholders, but also internal communications within this quite big team. This is another organisational chart taken also from OSVET plan, which is a local disease control centre. And again, just look at the number of boxes, the number of activities, the complexity that we're considering here. And I think this is the message I want to get across, is that it's not a simple sort of one-dimensional task. We have to consider disease control in all these different aspects of future planning, of current resourcing issues, of communications, of commitment, of sustainability. Leadership. We need strong, committed, sustained leadership. Now, typically that will come from our politicians, but it also has to come from industry leaders and stakeholders. That leadership has to be flexible because things will change. It has to adapt to our dynamic situation. And communications is critical to this because of this issue of change. We need to make sure that our leaders are familiar with good news stories, because politicians love to be able to tell how well things are going, but they don't like unknowns to suddenly hit them from the side. So we have to keep them abreast of things when things are not going well as well. So don't tell them short on information. It's really important that you have a close liaison with the leadership. I'm going to skip that one. I just thought I'd bring it into a little bit of context. We have to work within our individual governance systems. New Zealand is a wonderful country. I'm very fond of New Zealand. It's nice. It's simple. It's got a single centralised administration. very nice and easy. It's got a couple of islands, which gives us some nice barriers, and it's a long way from any other country. Isn't that great? Perfect country. Some of you will recognise this country, and we're very lucky we have Ibu Tata here, who you'll hear from tomorrow. This is Indonesia, which is a much more difficult country because it's very big. It's got something like 6,000 islands that are inhabited. It's got land borders with other countries. It's got a very decentralised political system. It's got 33 provinces, and I asked Tata yesterday how many districts we have now, and she didn't know because we keep making some new ones, but it's around about 460. And each one is autonomous. So to manage a disease control program in Indonesia is very much more complex than in a single centralised administration like New Zealand. It doesn't make it impossible, but you have to work within that administrative structure. Whilst in Indonesia, talking to the Ministry of Agriculture, I asked him if we could make something happen in a particular district in West Java. And he said, no, I have no authority, because they have this very decentralised system. So that makes disease control very difficult, because you do not have a tight autocratic process, a command and control. So you have to work with consensus. Now, there's nothing wrong with consensus, but recognise that you must work with that. So identify the issues of communication, of governance, of leadership, and then address them. So communications and management make it all work. So that's communication from the top, the vision, down into the activities, but then really the information back up. And it's a two-way process. In Clyde, and I guess talking maybe out of turn about Vietnam, we have a totalitarian government that is very strong centrally. And it says, do this, and expects everybody to do that. But the reality is that it doesn't quite work that way. But you need that dynamic information, that transparency of information, so that you know what is happening. You have to have clear understanding and openness. And if you do not get that, you have problems. So you need clear guidelines of SOPs, of what behaviours are expected, of job cards, of people's behaviour. And you need this dynamic feedback process of information on the disease situation up through the system, and the policy changes or policy directives down through the system. And that has to be a dynamic. Resources. We all know that resources are going to be key. We never have the resources we want. So using the epidemiology that we know of the disease, we need to focus these resources as best we can to get best impact. Who's going to pay? Is it government, private, some mixture? Maybe some international donor money as well. And of course we need resources right across the board. We need people, we need transport, we need equipment. You know all these things. How do we start? If we think of the first thing we need to do is really have a baseline assessment. So review the epidemiology and disease stroke infection situation. Do you know the incidence and prevalence situation in the country, the sector you're addressing? Do you need to assess that situation further? Maybe you need to do some baseline surveys. Do you have an effective outbreak response system, detection response system? Maybe you need to focus on that. You build up the community awareness, the community support. And then once you've assessed the situation and you're about to start the program, you need to plan into the system that process of review, ongoing review and adaptation of the program as the situation evolves. Logically, it makes sense to have a phased approach to any disease control program. So you're going to assess the situation, and then you're going to attempt to reduce the incidence and or prevalence of infection, disease. And then you'll probably go through a phase of some consolidation, when you just try and keep things under control, and at the same time reducing risk further. And then the final phases of elimination. You're actually trying to get to the point of zones, geographic zones, or compartments, production compartments that are free of disease. And again, in a country like Indonesia, where you have this wonderful archipelago of lots of different islands, you've got a wonderful opportunity for zoning disease control. You've got natural water barriers now, lots of boats and things, so they're never perfect, but it gives you an opportunity to reduce disease spread. So you can pick off the disease zone by zone. in modern farming production systems, particularly pigs and poultry, you have these highly integrated, well-fenced production systems. So you have compartments that you can work with. And this is useful because as you perhaps go towards a culling program, you need to have a source of healthy animals that you can restock from. So you need those animals identified as being free of disease and infection. So this issue of zone freedom or compartment freedom is a really useful stepping stone in the way to disease control. This is a diagram taken from FAO's an FAO document on foot and mouth disease control. And this is a staged process moving up from sort of fully uncontrolled infection, continuous FMD circulation, to full disease freedom, with reducing sort of issues of infection and reducing use of vaccination. And I think this is the concept of staging of disease control is really important. There's a funny saying that you can eat an elephant, but you must do it piece by piece. You cannot eat it at one meal. So you start at one place where you can start. You start making some progress. And that's a really useful concept from the issue of leadership, issue of sustainability, issues of commitment. Because if people see that you are making progress, then they are much more inclined to continue to support you. So the public relations issue in this communication is important. A little bit sort of more specifically on what's been happening in Vietnam. So the strategy in Vietnam is a phased program approach. Initially looking at reducing disease incidence in specifically man, because the great concern obviously was the issues of human health and potentially this development of a pandemic. But to do that we had to look at reducing the incidence in poultry. The next, and we're really still in that phase, the next phase was one of consolidation, so reducing the risk of the production systems, of the marketing systems, decreasing reservoirs of infection, and reducing opportunities for transmission. And then the final phase, which we're certainly not at in Vietnam, is issues of eliminating the virus from increasingly more compartments and perhaps zones within the country. So the sort of activities that we have in avian influenza control. Firstly, the surveillance. You want to detect not just disease but infection. And that's driven by issues of awareness and concerns about compensation. We need to target high-risk flocks, and we are using aggregation points, so markets and things like that. That creates us problems in the sense of tracing infection back to the supplying flocks, but it gives us an opportunity to, as a sort of sentinel population for a broader population, rather than just having to individually test flock birds. Then we look at issues of eliminating infection. So obviously we try and cull any diseased infected flocks. They're the usual tasks of cleaning and disinfecting premises, perhaps trying to trace at-risk flocks. It's a little bit of a challenge for us that, but the concept is there. And then risk reduction, so issues of producer and market changes. Public awareness. People need to know what to report, how and where to report, and really importantly, they need to know what to expect once you have reported. People are fearful of the unknown. They need to understand that if you're going to report, what to expect. And I'll come back to this point under compensation in a minute, but if I, as a farmer, report my birds are being sick, and cause all the village poultry to be killed, that doesn't leave me feeling very good in my village. So it's a very sensitive issue, and it's really important. So disease reporting is absolutely critical in terms of your sensitivity of passive surveillance. So issues of awareness, what should be reported? How do you manage the threat or the benefit to the individual? They need to know clinical manifestations that you're interested in. Are there problems? Can the clinical disease be hidden? That's a real issue if your compensation program is not working well. And if you have a clinical signs that are very similar perhaps to other diseases. That leaves you with a very weak, poorly sensitive surveillance system, detection system. This is there's a counterpoint in that if you have a public health problem, a disease like AI, with a public health threat, then there is more incentive to report. The integrity of this response can be helped by competent compensation. Recognise this issue I just mentioned in terms of the impact on the local community. So you have to maintain this reporting sensitivity and the transparency of the whole system. There's a real problem if this issue of transparency in the system. Am I causing problems?
No, you're not causing problems at all, just the lights. We just don't want to turn the lights down.
Oh,
I don't know where you do that. These ones here.
Sorry, it's a bit weak, is it? Okay.
Okay.
Sorry about that. Transparency. So I think we can think about transparency at a number of different levels. The first one is if as a farmer you have diseased animals, you need to have the level of competence that you are open, you will notify your local veterinary services. So that's the first level. Now, if the local veterinary services are not confident, then maybe they will assess the situation but not report it up to their district. And the same may apply, that's the second level. Then the district may also say, well, we don't really want the political nuisance of this, we don't want the economic quarantining of our district, so we will not report it up the system. And the same may happen at the provincial level, and the same may happen at the national level. And this is something that is quite common, and it's certainly something that happens in avian influenza in a number of countries. If you have a surveillance system like this that has no transparency throughout the system, you are walking around in the disease control program in the dark. And that's useless. You have to generate confidence in the system so that people are open and will share information, and it has to work right through the system. So it starts from political leadership and commitment, but it has to go right through so that the producers as well have confidence and commitment in that disease control program. And if we fail at any level, it weakens the disease control program or effectively makes it completely dysfunctional. So we need good reporting response systems. So we need veterinary services down to the local level, whether they're veterinary services or animal health technicians, it doesn't matter. But you need that grassroots sensitivity. Maybe you establish a hotline system, hot telephone numbers, or these SMS gateway systems that in Bangladesh are being used with, I think, a lot of success. Maybe you use third-point monitoring through slaughterhouses or markets so that you have at least some cross-reference in terms of, maybe you're not detecting disease, but at least you're aware that there is infection circulating. So you have some reliability assessment on your passive surveillance system. This issue of linking with health, unfortunately in avian influenza, it's still most commonly the situation in, I think certainly Indonesia and Vietnam, that the next human case is not necessarily associated with the poultry problem. The human cases are sentinels for the poultry disease rather than the other way around. Then you need the capacity to respond. So issues of training of staff, issues of staff protection, PPE, protective equipment. Issues of transport, they need to be able to get there. Issues of transport without fuel doesn't help anyone. So people often, you hear, will supply their own fuel. So again, there's issue of budgets and money. And then all the other necessary equipment in terms of sampling, in terms of cleaning and disinfection, in terms of managing that disease response. And then issues of data and information collection. Develop standard templates for the epidemiological data of your outbreaks or your cross-sectional surveys so that you have a consolidated data set of reliable data. No data set is ever going to be perfect, but at least try and get a standardized data set for any outbreak investigation or some cross-sectional surveys. So you make best use of this resource. And then report that information up through the system. Very often you will find that the information stays at the local level, at the district level or maybe at the province level, rather than being aggregated up into a national level. So you can really start to pick out different risk factors, different issues of disease incidence, how you might perhaps better focus your disease control. Compensation. I think we could give a whole lecture on compensation. Just a couple of slides on compensation. I think compensation is extraordinarily important. Probably one of the most critical issues of success. The philosophy is that you want to take away the risk from the individual. The reality is that people need to have confidence in their ability to report, that it's not going to hurt them individually, and perhaps more generally or more earnestly, it mustn't hurt their community around them. It's really hard to get the rate of compensation right. If you pay too much, you'll get disease-seeking behaviour. You pay too little, you'll get people dispersing infected, diseased birds or animals into the marketing system. It's a very difficult thing to get right. It's something that politicians don't like very much because it's seen as a straight cost to them. It's a system that is prone to rent-seeking. It's a system that is prone to abuse and corruption. How do you put some integrity into the system in terms of cross-checking? Now, in a country like Vietnam, they do pay compensation, but the compensation is controlled in such a way that the process is very deliberate. The document has to cross many desks. So the payment of compensation may take 3 months, more likely 6 months, and sometimes 1 year, which makes it ineffective. You have to pay compensation quickly, and you have to pay it at a realistic level.
So what do you mean by rent-seeking?
Sorry, rent-seeking, corruption. Rent-seeking is looking for money to pay into your pocket. Sorry. Sorry, it's a word that's used. Bad word. So corruption, basically, that people are abusing the system and taking money out of the system. Eligibility and compensation. What do you actually pay for? Do you require a certain standard? The farms must be registered, the birds must be vaccinated. Maybe you require that the owner of that farm or bird, those animals, actually did the reporting himself. So you can make a certain threshold that people have to achieve to receive compensation, which is fine in terms of maybe controlling the system, but it doesn't encourage the sensitivity of reporting. You want as many people as possible to report into the system, and then you filter it accordingly to reduce back to the disease that you want. And then what do you cover? Do you just cover birds and animals, or do you cover loss of income? Do you cover loss of equipment, materials, feed, buildings? So I mentioned Vietnam just now in the sense that it can take 3 to 6 months or often longer. Vietnam has a statutory policy of paying 70% of market value. But in reality, this is a political spin doctrine in that they pay 23,000 VND, Vietnamese dong. And that's about 30% of the value of a duck. So nominally it's a 70%, but the reality is it isn't 70%, it's 30%. And producers are not stupid. They know that it's 30%. Now that's not enough incentive. If you have 1,000 ducks and you're about to lose them all and you're entitled to 30%, well, how else may I make sure that I don't lose my money? So you have a risk that these infected birds are dispersed rather than reported. Nigeria took a very different approach, and Nigeria is certainly guilty of some philosophies of rent-seeking or corruption there. And they paid 150% of bird value. Very high. And I think innately we would say, well, there's a risk that you're actually going to draw in birds from different farms so that you can actually make more money. But in fact, they managed to make it work, and I think there is strong evidence now, and there are other factors at play, obviously, that Nigeria is now free of bird flu. And it's wrong to make a direct comparison with Vietnam or Indonesia or whatever. It's a very different environment with different demographics and things. But I think certainly the 150% compensation rate helped their detection process. So it is something that you want to get as high as you can, but avoid this actual disease-seeking behaviour. This map shows Vietnam as it pretty well currently is. So the concept of disease and infection, how much disease is unreported? So in AI there are many other poultry diseases that look like avian influenza, Newcastle disease of course, or duck plague or whatever. there's this ongoing fear of response, no compensation, mass culling, this issue of face in your community. There's also a degree of fatalism that poultry owners expect birds to die. So why do I bother to report? The map here shows the provinces that have had infection diagnosed this year. And you'll see that from the northernmost point of Vietnam to the southernmost point of Vietnam, and also sort of scattered through the middle, these provinces have all had clinical cases confirmed in the laboratory. But in fact, the number of cases is only 40 across the country, or 42, I think. So there are very few disease outbreaks across the country as a whole. So what's happening is that we have sporadic low incidence. But if we look sort of underneath this, we see that we actually have it sort of market surveillance and things, and I'll show you a picture in a minute, of infection across the country. So what's happening is that we're having a lot of subclinical infection problems. So passive surveillance is important, but it's only giving us the tip of the iceberg. We need to try and make that tip bigger, so we still have this issue of awareness and sensitivity and compensation. But we also have to recognise that no amount of clinical disease detection is going to resolve the problem. We have to get into the infection problems as well. And specific issues there of ducks. Older ducks did not show clinical disease well. There's a vaccination program in Vietnam, and that also masks disease. Case definitions. I think we need to think about case definitions. As epidemiologists, we all know about case definitions. We know they're critical in terms of our diagnosis, our disease control. But the reality is we need a series of case definitions. If you're a farmer, you need one case definition. If you're an investigating vet, you need another. If you're a diagnostician in a laboratory, you'll use another. And then as somebody responsible for confirming that disease, you'll use a different sort of algorithm as well. So I think it's important to realise that there's a hierarchy of case definitions that need to be defined and then used. And then monitored for the sensitivity of the process. In terms of diagnosis in the field, commonly we worry about clinical diagnosis, and it's certainly a problem in that we find that district vets will sometimes not want to diagnose the disease, and therefore they rule out on clinical signs, no, it's Newcastle disease. Now, most experts will tell you, rightly, I think, that you cannot, on clinical signs, differentiate between Newcastle disease and influenza AI with any certainty. You have to have some form of supporting diagnostic tool. Maybe use some of these fast pen-side tools, and this is a portable PCR machine. Not quite sure whether we'd advocate that. This is one of these little snap tests. The sensitivity can be less than ideal, but you use them serially on multiple cases, maybe 2 or 3 birds in a farm, your sensitivity increases. Issues there of costs, obviously. In terms of sample collection, you need all of the resources for that. You need training, you need staff, you need equipment. And you need to recognise the issues of numbers and samples, and then movement of samples, either if you're going to test them on the farm or you're going to send them to a laboratory system. I've only got an hour, haven't I? I'm going to run way over. Okay, I'll skip through some of these. We'll get through that one. Laboratories. Obviously, they're critical in terms of our integrity, our understanding, our reliability. So issues of laboratory QA, quality assurance in laboratories. Ideally, we want all our laboratories to have standard sort of ISO 17025, or at least some internal quality system. We have to have confidence in our laboratories, just as we have to have confidence in the passive detection system and in our active surveillance system. And laboratories are key to that. PCR is a wonderful technique, but it's something that can be abused. We can have problems with insensitivity if samples are badly handled. We can have problems of contamination, particularly with the conventional PCR. We can have problems sometimes with splitting of samples because people are trying to maximise the return from their laboratories. So lots of little issues there. I'm going to go a little bit quicker and catch through some of these. I just wanted to show you a little bit about market surveillance. Market surveillance is, I think, quite a useful tool in terms of as a sentinel for your population. It's a tool on the road to identifying where infection is. it obviously has problems in terms of your traceability back to the producer, but I think it's still quite useful. But it can create problems as well, and I just wanted to point this out to you here. So here's a table of various provinces in Vietnam. And this is influenza A. This is something that Roger's probably interested in, having been involved with some NZ-AID work. I'm not allowed to walk over here. NZ-AID work in South Vietnam. You'll see here we have very high prevalence, 27, 45, 46, 25% influenza A. That's an enormously high rate. You think of half this room on this basis will have influenza A. It's biologically not plausible. So there's something funny going on here. So we've got problems either with contamination at the time of sampling, or some sample transfer into the laboratories, or within the laboratory system. Here we've also got H5 and things, and we've got some quite high rates of H5 here. These are not sick birds. These are healthy birds at markets being tested. And this is by PCR test. Individual birds, these are not environmental samples. So I think we have to be very careful about assessing the information that we're provided by surveillance activities, and certainly out of the laboratories as part of that. It's very easy to just accept things that we're provided with, but we need to critically assess them. The process of confirmation, I've mentioned that already under the this case definition process. It's an important issue as to how you formally confirm disease. Who does it? On what information they are required to do it. And it really needs experienced case managers. It needs to be at a certain level within the veterinary services. It sounds as though it's being overly micromanaged, but you need to have some confidence in the system so that it's reliable, it's repeatable. And then you need to follow this up with confirmation. What are the next activities? And again, the first thing is communication. Who do you need to tell what to, and what activities will follow? Just a quick example from an outbreak in Vietnam. There was an outbreak here in this province, Xinjiang, which is down in the south near Ho Chi Minh City. And this outbreak came, there was a market about here, and it was supposedly caused by ducks that were bought in the market. And the market received most of its ducks from the next door province, over to the west here. But nobody would talk to the next door province, because it was a human case, but there were no confirmation in poultry, and therefore there was no contact formally with the next door province, although that was the most likely source of infection. So issues of lines of communication are critical. You cannot take these things in isolation. So again, it goes back to this issue of management, issues of communication to the other parties, other broader stakeholders. I'll go past that. One of the things that we face, particularly in some of these international donor programs, is issues of humane culling. And here you've got just a simple carbon dioxide system, which seems nice and simple. You need a wheelie bin, you need a carbon dioxide cylinder and a hose, and that's okay. There should be a regulator on this, but there isn't, so that's a bit of a problem. If you turn that on, you're going to get full face sort of blast of cold carbon dioxide, so there's some issues just on the slide there. But it's a big problem in terms of resources and equipment. If you have a diffuse problem with outbreaks of disease, as you get in these endemic countries, how do you have this equipment to hand? So the logic is that other systems are used, and it's a big problem for the donor community, because the donor community are very keen on humane culling, and they want to see these sort of things happening. They don't like bloodletting or throwing into hot fires or anything like that. So it's something we have to manage because the money is important. A couple of minutes on vaccination, then I'm going to wrap up with just a short thing on rabies. Vaccination is a really useful tool in some diseases, in some situations, but recognise that it's not a panacea. It takes a lot of resources. Is it the right use of the resources? Should those resources be used for more sensitive detection of disease, or for better response or better risk reduction? There are problems with vaccine both in terms of the use of resources, but also it doesn't usually provide you with a sterile immunity. So in AI, you can vaccinate birds, but they can still passage virus. You'll get reduced clinical signs, good, but bad because you'll not detect the disease situation, or you'll be less able to detect the disease situation. It's good that it reduces the susceptible population, so it's going to reduce your disease transmission, but it doesn't eliminate it. So it makes subclinical infection more difficult. And then if you're monitoring flocks, is your titer from vaccination or from a field infection? So Vietnam's been vaccinating millions of birds now for 5 years pretty much. The government doesn't like it. It's saying it's paying too much money into this vaccination program. It's only been vaccinating twice a year, in a May period and October. But poultry have a short lifetime, as you know. So what happens is you get a lump of immunity, and then the populations change, and the immunity is up and down and up and down. So yes, it's had a benefit in terms of the disease incidence, but it's by no means eliminated the problem. And here you see a table of the disease incidence over time, and you'll see the very high bars in the chart for the early years here, for the first 2-3 years, 2003 to 5. Vaccination was introduced in late 2005, and it looks as though, and there were other activities as well going on in terms of banning of breeding of ducks and improving markets and trade issues, but we can see that, yes, we've had a good reduction, but we're still having ongoing endemicity in the population. So we've had a dramatic reduction, and certainly the human cases have come down as well. But we still have problems. We have issues of detection of outbreaks, this issue of rounds of vaccination, annual rounds. We'd be much better off with age-based vaccine. Issues of subclinical infection and sustainability. Who wants to pay? So we need to continue with other control measures. I'm just going to show. Avian influenza, as you know, is an RNA virus, and one of the problems with it is it moves around, so it doesn't remain stable antigenically. This is some quite nice work that's now being done in terms of virus monitoring in Indonesia specifically, but also Egypt and starting in Vietnam. And it's mapping this antigenic change. For vaccine to work, you need a good fit between your vaccine and your virus. But if the virus keeps moving around, you need to monitor that. Otherwise, your vaccine will lose its efficacy. And there's some nice work which is done off HI titers and cross-mapping. And the one on the left there shows you actually some human viruses, H3N2. And the one on the right there shows you what's happening in Indonesia. And maybe it's not so clear here, but you could see from the earlier 2009 to 2010, you can see how there's an increasing population here, which are a couple of log titers away from these here. So what's happening is that the virus is moving away from the vaccine. So it's something you need to monitor. So the point is that vaccine is useful, but you can't shut the door and say, yes, vaccine is useful, and just keep it rolling. It costs money, it costs resources, it has problems in terms of your ability to detect disease because it tends to promote subclinical infection. But also, you probably lose vaccine efficacy over time. You must monitor your circulating viruses. So again, back to issues of surveillance. It's quite interesting in Vietnam, and it's probably not terribly clear here, but Vietnam in the south has clade 1. In the north, it has clade 2.3.4 and 2.3.2, which is useful information, again, this virus tracking, in that it tells you that you have separate populations of infection. So there seems to be very little movement of infection up and down. Now that's a useful tool. If we're going to move towards zoning, it suggests that we don't have a lot of transfer of virus between the top and bottom of the country. So the use of epidemiology, virus monitoring, is important both in terms of the sustainability of the vaccine program, but also in terms of our longer-term game of getting zone freedom and compartment freedom. So monitoring and surveillance is important at a number of levels, obviously also specifically in terms of monitoring the effectiveness of the program. We all want to see that our program is making progress, particularly our leaders and financiers. A couple of slides on just training. So training is obviously so important. I'm in danger of running out of time. Staffing is what drives these programs. Staff need to know what to do. Issues of job cards, issues of SOPs, issues of hands-on training. These are simulation exercises in Vietnam. I love this photograph, so I'm going to waste time and show you this quickly. Here, I think it's interesting risk management. We have people in PPE, but they've all driven there on their motorbikes. So they've got their helmets on. Now, I'm not sure that helmets are really necessarily part of PPE. So I think we've got a slightly confused message here. I'm particularly worried about this chap. He seems to have got his eyes covered up as well. Maybe I see no ships. So we have to be careful. So,
given your late start and with Joanna's permission, could we just give him till quarter after or something? Does that help you?
Yeah, sure, thank you. Okay. Thanks, Eric. So PPE is obviously with zoonotic diseases. We win no prizes if people become infected as part of the implementation program. So it's really important that people are trained and are adequately equipped to protect their own health. And that applies at the field level, it applies at the laboratory level. So laboratories need adequate BSL facilities, adequate hoods, adequate cabinets. In the field level, in Asia, it's tough. PPE is not much fun in a 30, 35 degree environment. I'm not sure that the risk of PPE is probably greater than the risk of avian influenza. I think hypothermia and deaths from cardiac arrest is actually higher than PPE, but we don't win any prizes. We cannot afford to get people infected as part of the program. That would kill the program or harm it very badly. So it's mandatory, we can't avoid it. I think there needs to be some innovation in terms of more comfortable PPE. And I think we need to also sort of risk manage PPE a little bit, to get people spraying like this with a heavy motorised backpack in full mask PPE. I'm not sure that that's really necessary. If you're vaccinating hopefully you're only vaccinating what are at least perceived, if not known, to be healthy birds, do you need full PPE? Certainly you need to take care that you don't transmit infection, but I think the exposure should be low, so I think aprons and face mask and goggles are enough rather than full-suited PPE. So I think we need to think through this problem a little bit more than this sort of just mantra of wearing full PPE most of the time. The other issue which many of you will be aware of, in Vietnam I think has some of the smallest people in the world. The average man in Vietnam is 55 kilos. Now, you make a PPE suit for me and it may fit just about. It's usually big and uncomfortable on me. But you put it on a guy this big and he's got hands this long and feet this long, and then you expect him to go and work. We've got to do better. It's not good enough. Okay. So here we are. Yeah. So, again, a bit more practicing in Vietnam. So here they are all lining up. They love gameplays and things. It's really useful, I think, that we do go through these simulation exercises. The problem with simulation exercises in Vietnam, and I suspect in some other countries as well, is that they're too tightly scripted. So it's like following a theatre of, alas, poor Yorick, I knew him well. You follow by rote, and you're not problem solving. You need to do simulation exercises are very useful in terms of activity and practicing activities, but we need to come up a level before that and say, what are the problems we're facing with? What are the risks we need to consider? What are the opportunities to reduce this disease, eliminate the reservoir, reduce the transmission? So here we have these very tightly scripted exercises in Vietnam. And again, we have the motorbike helmet. 3 years ago, nobody in Vietnam wore motorbike helmets, but now they wear them everywhere. I don't know why. Children are a fantastic opportunity in terms of awareness. Now, all things cost money, so there's always going to be a balance between how we focus our communication and extension activities. But children are wonderfully receptive. They're a wonderful key into adult thinking. They're probably the best method of changing behaviour and changing awareness and changing alerting. And we have some really nice school exercises running in the project I work in Vietnam. And these kids get very involved. We get some great play acting between these folk on the left. Here's a young vet holding a duck up to a trader. And it's lovely. They get really involved and they go home and they talk about it to their parents. And I think it's something that we probably don't do enough of. And again, it's this issue of communication and awareness. Last slide, I think, for AI, and then I'm going to talk for a couple of minutes about rabies. So, how do we get to the end? We have to be extremely careful about ending prematurely. You stop the program too soon, and you run the risk of infection breaking back out, which doesn't help you politically, and it puts the whole system back on its heels. It costs you more money, and it's a bad game. Governments and stakeholders run the real risk of losing interest. As the incidence of disease comes down, other priorities will take over. And we have to recognise that, social and economic priorities are much broader than animal and some aspects of public health. How long should we continue vaccination? Vaccination masks disease. So as soon as possible, ideally, you would take vaccination out of the system. And this is a situation in Vietnam, and I showed you this before. So here we have low incidence. Should we cut vaccination out? Yes. If we have a decent system for detecting disease, and we have some confidence that infection is no longer widespread. Well, I don't think we have either of those right at the moment. So the recommendation at the moment is to continue vaccinating. But that's not sustainable. So we have a problem in that we have an ongoing low-grade endemic. We have an ongoing vaccination program that masks disease, and nobody wants to continue with that. So we have this sort of dilemma as to how to go ahead. So the logic at the moment is that we continue with vaccination and try and reduce issues of reservoirs and issues of transmission. But that's easier said than done. As soon as you remove vaccination, you're innately going to increase the susceptible population, and therefore you would expect an increase in incidence of disease. And in avian influenza's context, you would expect there to be more human exposure and therefore run the risk of more human cases. You'll be aware that there are formal sort of processes of freedom, declaration of freedom under the OAE pathway system. To do that, we need to use multiple data sources, and there are clever people that know how to do this much better than me, using multiple data sources over time to demonstrate freedom. And we think about this perhaps holistically in terms of the whole national program, but in reality we need to think about it also in terms of zone freedom and also in terms of compartments. So ongoing monitoring and sensitivity of disease detection, ongoing cross-sectional surveillance, detection of infection. A couple of slides, just a complete change of focus now. Just a case example of rabies. So rabies in barley. Barley has been free of rabies for many years. Unfortunately, in 2008, a case of rabies was detected in barley, and it was detected right down in the south of barley, down in this area here. But unfortunately, the detection was perhaps a little bit late, and the response was certainly a little bit slow. So now this map shows you, and I'm sorry you probably can't read it, but it shows you the distribution of rabies in barley, and it's basically green indicates that there are cases being identified. Sorry, not the dark green. Everything but the dark green is indicating a case. So you can see that from the westernmost point to the east, north to the south. So rabies is now island-wide. The initial response was to try and reduce the dog population using strychnine and some vaccination. There have now been more than 100 cases in man, and there's a suspicion of quite a big problem with underreporting. There is funding both locally and nationally and international funding. So there's some big problems there. There was an opportunity to wall it off early on, but like all these index cases, if you don't pick up that index case very quickly, then your opportunity quickly vanishes or at least becomes more difficult. So why was there a problem? There's little motivation on community support because there's a very strong culture of dog ownership in Bali. The culling program using strychnine is a fairly nasty poison. It's not a nice thing to use on anything. So if you're going to try and cull animals, you're better off to use something other than strychnine. So it's unpopular culturally within the community. So you're not taking the community support with you. And that is absolutely fundamental with any disease control program. If you do not have the support of people, and particularly the animal owners, you will never win. Vaccination coverage was poor, and that was driven by issues of logistics and management. Bali has a very big dog population, so that makes it difficult. the decision was made to use a locally produced vaccine that required 2 shots rather than the single-shot vaccine. So all of these things compounded to allowing rabies to spread across the country. And you can see here is the blue lines, this year's cases of human cases, and here over time. So you can see that the situation, and these blue lines, sorry, you can't see, these are recent months, are still low because of probably cases still coming in to be unreported. But you can see the outbreak of the epidemic is still increasing. At this stage, no tourists have been infected, but they're probably only a matter of time. So the Balinese economy is very tourist dependent. So it's a very tough call economically and financially on the island as well. So current strategy: trained, equipped vaccination teams, good. Vaccination progressively village to village, banya to banya, not merely targeting hotspots. So there was a little bit of a risk of just sort of spotting across, chasing cases. Now there's a sort of progressive sweep across the island. Increasing community awareness and support. The aim to get vaccination up above 70%. Rapid response on clinical signs, including euthanasia of in-contact dogs. Okay, that all makes sense. So challenges, though. Problems. The drugs that they prefer to use for euthanasia are muscle sedatives and barbiturates, but they're not licensed in Indonesia. So there are some issues there. The welfare groups that are, big international welfare groups that are sponsoring this, want to use these humane euthanizing agents, but they can't. So we have a political policy sort of moral dilemma on that one. Island-wide vaccination. One of the 9 districts doesn't believe that that's the right way to go. They want to go for a confinement and a culling process. And this is always a problem if you have a disease control program that there's an outlier, a district, a province, a farm that is not compliant. That weakens your whole program hugely. You have to try and get coherent commitment to this. Comprehensive commitment right across. Issues of sustainability. They want to try and continue this vaccination program for the next 2 years and aiming at this high coverage. The suggestion is that R0 is quite low at under 2. So that suggests that your vaccination coverage at 70% for relatively long-lived animals should be good, should be okay, particularly if you're using this vaccine, the single-shot vaccine, rather than the local-shot vaccine, which requires only a single dose. Just to comment on logistics, the recommendation is 50 vaccination teams for island-wide program, and each team will have about 6 people. So a vet, some dog catchers, and a recorder. So again, all of these issues, when you're building your operational plan, you need to think about numbers, about activities, staffing, equipment, transport costs and things, and all of these come back into this issue of disease control. So each team needs to vaccinate 1,400 dogs per month. Now that doesn't sound too many, that's only 50 dogs per day, but if you're actually having to catch semi-wild dogs, that's quite a task. So possible, but not necessarily easy. Okay, last slide. One. Successful disease control programs need strong vision leadership, clear objectives, and this strong commitment, and really a commitment right through, either through just innate commitment or, if necessary, some legislative commitment that they have to do certain things. You need good planning, strong planning disciplines with reviews and budgets. You need to address the issues of motivation. What's in it for me? Ultimately, people are selfish. If it's not of their self-interest to do something, then they may do it, but they may not do it. So look at the issues of motivation. Issues of transparency. If you're working in a disease control program where you know half the information, maybe you can manage. If you have really imperfect holes of what you don't know, it makes it very difficult. You're walking in a fog. And that's all issues of communication. How do you drive this commitment? Resources, obviously critical. Monitoring and evaluation, ongoing and necessary, both in terms of program management and in terms of supporting the leadership. we need to continue with epidemiology and surveillance to make best use of what are always limited resources, to make sure that our disease control program is on track and review and retarget, refocus as necessary. I've already mentioned transparency. It's very important. Just want to again just acknowledge the Massey Epicenter. I want to acknowledge my employer in Vietnam, FAO, for letting me go. World Bank actually paid for me in Vietnam, so I must acknowledge them as well. OIE, industry and Vietnamese departments of agriculture for sharing slides and allowing me to work in what is great fun, and I love it. It's a great work experience. I don't think you haven't got this. There are some websites here. They'll have access to this electronically, Joe, I think. So in terms of disease implementation, websites at FAO and OIE have some really excellent documents. They're very big websites, so they can be difficult to find things in. Here's a place to start if you want to look at, and a couple of specific papers there. Thank you very much. Sorry I've run over time. Thanks, Eric.
Thanks very much, John. That went away.
Oh.
But yeah, I think that was a great job of the framework of implementing a disease control program and some real examples of the challenges in meeting what's ideal. And we'll take 5 minutes for questions because this is our opportunity to
Dr. Dilip Kumar Ghosh from Bangladesh. Thank you, sir, for your nice presentation. You have a long experience. By this time we informed that you have worked in Vietnam and worked in Indonesia. Regarding H5N1, you mentioned in your paper that vaccination have already been very successful in Vietnam. Dramatic sales have been seen in Vietnam. But so far we know some officials visited Vietnam last year and we informed that in village level, in commercial and organized farm level, vaccination 100% successful, have already been successful. Vaccination successful, become successful. But in village level, somewhere after vaccination outbreak have been seen. Somewhere, some places, in sporadic form. Like Indonesia, we have been informed that after vaccination, outbreak have already been seen. In this situation, I want to know what is your additional experience, what is your additional comments regarding vaccination against H5N1 in less developed countries. Thank you, sir.
Thanks, good question. I think the information is less than perfect. In the Vietnamese situation, the disease outbreaks that we have detected in the last 12 months, none of them have occurred in vaccinated birds. So I think there is strong evidence that vaccination protects against clinical disease. But we also know that vaccine does not prevent infection and does not prevent low-grade passage of the virus. It certainly would reduce your virus excretion. So there is a benefit in the system, but it is not a solution to the problem. So, and I think it's certainly, if you look at other activities that have happened in Vietnam, there was a ban of duck breeding for 12 months. There has been some effort in terms of improving marketing, in terms of cleaning up markets, in terms of improving trader and market behaviour. But I think if you look at the whole, the issue of risk reduction in terms of these transmission routes has been relatively little. So I think we have to probably assume that a lot of this reduction in incidence in Vietnam is attributable to vaccine. I can probably be shot down on this, but I'll make that statement at the moment. So I think it has a value there, but I think we now have a big problem because we have low incidence of disease, but we have wide evidence of infection, and we have an unsustainable vaccination program. Somehow we have to get rid of vaccine, or at least use it in a sustainable way. So it's been useful, but I don't think we've in any way solved the problem. In the Indonesian situation, and Tata may wish to comment here, there is strong evidence that the commercial sector have been using a lot of vaccine in particularly long-lived birds, layer birds. And what's happened there is that we have got evidence of some quite different antigenic type viruses appearing. So yes, again, they've suppressed the disease, but they've still got the virus moving through the system. So I think, in a purist way, it actually complicates the disease control, but maybe because of issues of gross virus circulation transmission, it has suppressed that, and therefore it has had a benefit in terms of human health to a degree. You can face one way, you can face another way, but I think one can be very sceptical and say, well, in fact, we'd be better off not to have done it at all and just relied on boosting things like disease detection and reducing transmission. And it certainly complicates your surveillance program hugely. So I sit a little bit on the fence on this one. I think we can probably argue that it has been useful in terms of protecting human health, but I think we're still on the horns of a dilemma in terms of how to get off the issue of vaccination now. I think there's probably many people around this room who might make other comments. I can see Roger is... Sorry, I didn't quite catch that. Is there any...
Does this vaccine behave differently in ducks than it does in chickens?
The vaccine? Does the vaccine behave differently in ducks and chickens? Yeah, but you can get good immunity in both ducks and chickens. You can get good levels of protection. You do challenge tests and things and you'll get no mortality in either species. Your immune response is different. Ducks tend to have much lower titer responses. So if you're just looking at simple blood tests of a population to assess their immune response, ducks will be quite low, and they're not. So you don't get good correlation between immune response and protection. So there are some complexities there, but certainly in terms of just issue of protection against disease, yes, you protect both. Ducks are more likely to excrete higher levels of virus when vaccinated than chickens. So there are species differences, but you can protect them.
Okay, thank you very much.